Welcome to the SIBO Doctor podcast, hosted by Dr. Nirala Jacoby. Medical experts join us to discuss functional digestive disorders, clinical practice and research as it relates to SIBO and associated conditions. This podcast is intended for SIBO treating practitioners and aims to help educate how we may best serve our SIBO patients. Head over to thesibodoctor.com and sign up to the SIBO Mastery Program and take your SIBO knowledge to expert level. If you're a patient, you can sign up to the SIBO Success Plan and beat SIBO for good. Please note, this podcast series is not intended to diagnose or treat medical conditions. Ask your doctor before initiating any new treatments. And now, over to Dr. Jacoby and the latest episode of the SIBO Doctor podcast.
Welcome to another episode of the SIBO Doctor podcast. I'm your host, Dr. Nirala Jacoby, and today the topic of this podcast is chronic pain. And pain in general, which is prevalent in many health conditions, including IBS, SIBO, and other digestive disorders, as well, of course, as the common joint disorders and autoimmune conditions that many of your listeners may have. Today, we'll unpack some of the mechanisms that drive chronic pain with a special focus on how dietary factors, microbiome imbalances, and the nervous system play a role in the development of pain. My guest today is Ananda Mahony, a naturopath with a special interest in helping people struggling with arthritis to endometriosis to digestive pain or any condition where pain is a predominant feature. She has developed programs for groups and individuals to help resolve chronic pain and get back into life. Ananda has completed a master's degree in pain management. Welcome to the program, Ananda.
Thanks for having me, Nirala. I'm excited to be here and talk about pain and diet and whatever else we come up with.
Great. Yeah, I saw you in Paris and I thought I got to have her on the program because you touched on so many factors of pain that I think really apply to a lot of people, whether they have chronic pain issues or even digestive pain. So let's get started with the conversation by just tell us how you really got into this topic.
Yeah, that's a good question. And sometimes I look back and wonder how I got into this topic as well. But essentially, I was working in a clinic with some musculoskeletal therapists and they were referring patients to me. And what I realized is that there was a lot I didn't know about chronic pain and some of the strategies that I'd been trying in other chronic conditions and used successfully with patients, and the things that I'd been taught in college, through naturopathy just weren't working. I was dampening down inflammation, I was changing diets, I was working with stress responses, but they weren't working for chronic and persistent pain in some patients. And I got a little bit curious about the topic and ended up doing a master's in the science of pain management. So I kind of delve into it a little bit more deeply than I thought I would, but I just found it so fascinating learning about something that it was about 8 to 10 years ago I started that, there wasn't a lot of information about. But I think that the area is, there's more information out there for consumers and patients now, but back then it was quite limited. So that's really good to see.
Yeah, I remember, we also as naturopathic practitioners we have our favorite sort of herbs and things like that, but really the whole pathways of pain are actually really fascinating. And I wondered if you could just give us sort of a basic primer on pain perception and how the body deals with pain and what's going on there.
Yeah, I sure can. I think the first thing that I would say is that it's complex and pain is also multifactorial. We can't just focus solely on tissues or damage or biomechanics. And I think it's critical to view pain through the lens of the biopsychosocial framework. And so that means considering psychological inputs, if you like, or psychological drivers and social factors, as well as those biological or biomechanical factors. And that is the first point. And fortunately, that is the predominant viewpoint in the pain research, and it matches very well with that naturopathic concept of mind, body, spirit. So we're looking at the whole person, and that's I think the only really thorough lens to look at chronic and persistent pain through. But before I go into chronic pain, I'll probably give a little bit of a primer, very short, about acute pain. Because when considering pain, it's really important to know that acute pain is very different from chronic pain. And most of us, I'd say everyone, has had an acute pain experience. And so we think we understand pain. And usually there's a clear cause. It's pain following an injury or even the threat of an injury. And acute pain is a protective response, or if you like, a survival response. It alerts the body of potential danger, and we respond in a protective way. So the example would be picking up something hot, and we drop that because that protective response is to let go of the hot kettle or cup of tea or whatever it might be to prevent further injury and damage. Pain of this type, acute pain, is usually of limited duration, and it subsides long before healing has occurred. Another example here would be a twisted ankle, where or you roll your ankle and immediately it's painful. And that pain is a warning to not put pressure or try to walk on that ankle, because it may create further damage in that moment. But usually the pain subsides a long time before complete healing of the ankle has occurred. And that is a real characteristic of acute pain responses, that the tissue still might be a little bit fragile or a little bit delicate. There's not pain associated with walking on it anymore. And so it just takes a couple of days and that pain starts to resolve, but the tissues take a little bit longer. Speaking of that, though, thinking of that example, I think another key point that I want to make is that pain isn't created in the body at the site of the injury. We think pain is there because our ankle's sore, but pain might be experienced in the body. However, it's created in the brain. And I can go into that in a little bit more detail if I've got the space and the time to do that. But I guess an explanation of how pain is created in the brain is probably important here. So first, thinking about the nerves, and we've got nerves, and they're specialised nerves called nociceptors, and they're all over the body, and they're sensors for noxious or unpleasant stimuli. So when they detect a change or a threat, and that threat could be damage, hit our thumb with a hammer, could be inflammation, it could be some other change in the local environment, like a change in pH or a pulled muscle or something like that. These nerves, nociceptors, send danger signals from the body. At this point, they're not pain, they're just danger signals. And the messages travel up the spine to the brain, where the information is evaluated in the context of the situation. And then the brain decides how to respond. So, is this an emergency, or is it just a paper cut and a false alarm? What needs to happen to keep me safe and protected? So if there's any reason to think that protection is needed, the brain creates pain. And it's very context-driven. And the brain is our central driving system for that context-driven response. And the brain influences pain intensity and duration and pain type. Sorry. No, I've just realized I've talked for a long time already.
Yeah, no, that's okay. It's all super fascinating. We all can understand the kind of acute pain, I think. And but when we go into chronic pain, it gets really a lot more complicated. But one of the reasons I wanted to talk to you is because when we're dealing with pain, whether that's osteoarthritis or some of the more chronic pain pictures, as naturopaths, for a long time, we've always looked at diet, and we looked at other components of a person's lifestyle that physicians wouldn't necessarily consider with pain management, because in conventional medicine, it's all about just pain management through the use of medications. We have different types of tools that we utilize to that are more looking at pathways of why something is painful, whether that's inflammation or other aspects of the immune system. So can we kind of veer into the type, maybe not the type of pain, but what you found through your research of what directly impacts pain when we're talking about diet, for example?
Yes, absolutely. And I think that probably I'll just do a little bit of an explanation of chronic pain, and then I'll really strongly link that with diet, because this is when I was looking at the research, this is what came through very strongly. There's implications for dietary strategies that can really make a difference in chronic pain states. But to talk about that, I want to go back and talk about some of the mechanisms that drive chronic pain. I'll just be brief, I promise. So chronic pain, as I said, chronic pain, as I said, is really different from acute pain. The point of pain, acute pain, is to generate that protective response like an alarm. But like all alarms, if they keep going off long after they're useful, they become a problem. And in chronic pain, the alarm becomes disconnected from the initial problem. So there are changes in the nervous system, and the nervous system becomes programmed to a hypersensitive, overprotective setting, which means that the body produces increasingly painful responses and pain is amplified. So it's disconnected from whatever issues there were in the tissues. And it's disconnected even from some of the context in which pain is usually created. So people can start to experience more pain with less signals from the body, or more pain with the same amount of signals, or even pain with no signals at all. And
wow. Can you give us an example of that? Like maybe you had a patient or so that perhaps had something like this?
a classic example would, yes, I'll give an example of pain being created with no signals at all. It is an acute pain story, and that is the example of a workman in the 1950s, and he was on a work site, and he had work boots on, and he jumped down, onto a nail, and a big nail went all the way through his boot, and he was in agony. And he was, of course, rushed to emergency, and he was in so much pain and distress that they kind of had to sedate him before even trying to take the boot off. And when they finally removed the boot, what they found is the nail had gone between two toes. So there was absolutely no damage at all. That is an example of context where there's absolutely no nociceptive input from the body, and yet someone is in persistent pain. So when we've got a chronic pain setting, and when there's hypersensitivity in the nervous system, the immune system gets involved in this and causes something called neuroinflammation. And there's a whole lot that starts to drive amplification of pain responses to the point where pain is being created to protect the body even when there's no need for protection, or even when the pain is detrimental. And in essence, in this case, the brain learns that pain is the go-to response, and it becomes a vicious cycle of threat perception. And the threat doesn't have to come from the body. It can come from thoughts, emotions, everyday movement, situations. And that threat perception leads to amplified pain responses. And
so this is kind of like a learned, but it's subconscious. Obviously, a person is not aware of this, but it is a learned behavior. So what you're saying is that there's all new kind of approaches to pain management that don't necessarily involve medications that address the pain.
Yes, well, they don't just involve medications that are working on dampening down local tissue concerns, or what people think are driving the pain. So if people think it's damage, it's not focusing on the damage, because often pain is unconnected from damage in the tissues anymore. Or there might be inflammation, but it might be low-grade inflammation. It's just that the threat messages from that inflammation are being amplified and the pain is being experienced in a more severe way or a more prolonged way than it would in an acute pain setting. It is hard to say because pain and tissue damage are not closely aligned. We think that they are, but they're not.
Well, I often, have this experience with patients where, for example, they have what they believe is gastritis, they have a lot of stomach pain, and on an endoscopy, it's perfectly fine. There's no damage whatsoever. Could be a lot of different sources of pain, but I do think there is this component where the pain may have been initially there, but it continues to be activated in some other way that's not necessarily connected to tissue damage, So I find that really a whole fascinating concept. But can we veer now to the to the dietary influences? Because pain is, we're not saying that pain is all in somebody's brain, right? It is in some way, but those of you listening that are in pain, this conversation is really just a platform to discuss different types of approaches to pain rather than always thinking pain needs to be mitigated through medication, because that's I think a big deal. A lot of people are taking painkillers and pain medication, whether that's NSAIDs or other types of medication that aren't necessarily all that helpful in the management of pain. So I wanted to have this kind of veer into what you found with your literature review or research review of how pain was influenced positively or negatively with different diets.
Yeah, absolutely. I can talk probably first about some of the research into dietary influences that might be sustaining or maintaining pain. So there's some processes that occur that implicate in the transition from acute to chronic pain, and they're the potential targets for nutritional inflammation. And that's that neuroinflammation and central nervous system sensitization. It was part of the research that I looked for. And essentially the premise of this is that there's potential for pathological adaptation of the nervous system occurring in the context of a persistent increased inflammatory load from diet. So the diet's driving inflammation, which is then impacting that central nervous system hypersensitivity. And the foods that are implicated in that are high fat and high sugar, and I'd say also, while not explicitly stated, ultra-processed foods, because they're often high fat and high sugar. And what we know about high fat and high sugar is it's positively associated with pain intensity and a reduced pain threshold. And that is thought to be through the dietary induction of that nervous system hypersensitivity I talked about. And there's various mechanisms, and I can talk through those if you'd like me to talk through how that happens.
Sure. I think just summarizing or briefly mentioning some of these pathways is really useful for people to really get a good picture as to why it's helpful to reduce these foods if they have pains, any kind of pain, really.
Yes. And this is for any kind of pain. I looked at in the literature review specifically at musculoskeletal pain, but this research was not, didn't take that such a narrow focus. It was for all kinds of pain or all kinds of chronic pain. Some of the mechanisms are vagal nerve activation. The vagus nerve informs the brain about all sorts of factors such as dietary intake and nutritional status and peripheral inflammation. And, if there's a lot of input to the brain saying that there's a lot of inflammation here, it can lead to immune activation in the brain and central nervous system. And of course, diets high in saturated fat and sugar can also induce changes in the gut microbiota, and that can directly and indirectly lead to inflammatory responses, again, in the brain or spinal cord, which contribute to the onset and progression of pain. There's induction of oxidative stress, which activates toll-like receptors, and I just kind of think about them as like sentinels for danger, and they've got a really long memory, and they activate the brain and central nervous system again. So all of these factors lead to that sensitization and amplification, or have the potential to amplify pain. And there's some preclinical studies that support the idea that if we can use nutritional interventions that lower sugar and shift the ratio of fatty acids, so shift away from high-fat diets or even high saturated fat diets over to mono and polyunsaturated fats, then we can potentially inhibit nervous and immune activation and lead to a diminished central nervous system sensitization and thus reduce pain amplification. Now, it's unlikely that just cutting out fat and sugar will clear up all your pain, but it may actually just reduce the severity of pain. And I think that that's a pretty good starting place. And specifically also because high fat, high sugar and ultra processed foods are linked with a whole plethora of chronic disease states anyway. So there's further benefit.
Metabolic disease, etc. But I want to mention here about the fats, and it's mainly saturated fats, and they're found in animal flesh, really animal products, including dairy, but also coconut oil. You know, there was a study that looked at increased absorption of lipopolysaccharide, which of course is the inflammatory substance that I so often mention on this podcast, that's in the cell wall of gram-negative bacteria. So when they are overgrown and you eat a lot of saturated fat, it's been shown that the absorption of this inflammatory substance is greatly increased with this type of fat. So that's just one mechanism of how saturated fats can really drive some of that inflammation. And this is always where a lot of the paleo people start to pipe up of how their pain has been greatly reduced potentially by going paleo, especially when they've had an autoimmune condition. So this is, you know, we're just talking about pathways that we know this happens, and it may be different for you who's listening because you have different types of situations happening that are maybe not just saturated fats or animal products. But in general, what you're saying is that your research has shown that those are the two main factors sort of generally on the diet, but then there were also other studies that looked at food allergies and pain. Can you talk about that a little more?
Yes, this was a recent research in the literature from 2022, and I hadn't seen research like this before, so I was really interested. And this looked at immunoglobulin and IgG4, and I guess the concept of food intolerances, perhaps driving or exacerbating chronic pain. And immunoglobulin IgG4 are food-specific antibodies that result from exposure of the gut immune system to certain nutrients or food components. And it's produced by the immune system just to advise about that particular food that's being eaten. So high levels have been associated with inflammation locally in the gut and increased gut-related issues. But in this study, the researchers were looking at the broader systemic effects of high IgG4 levels and if there was an association with chronic pain. And so the study itself had 54 individuals, and they from various different primary pain types. There was neuropathy, diffuse pain, which is akin to fibromyalgia, back pain, and headache. And all the subjects had suffered chronic pain for more than 1 year. And the researchers tested their immunoglobulin levels to a wide range of foods. And what they found is that 87% of the subjects in the trial had high immunoglobulin levels, high IgG4, to more than 5 different foods. And across the board, and sorry, I should just go back a bit, all of those profiles of the IgG levels for the individuals were quite different. So it was a very individual food responses, food results, if you like, or IgG4 results. but they're across the board on average, the highest IgG levels overall were for eggs, dairy products, grains, and dried fruit. And then they did an intervention, so they did a 1-month exclusion diet. And what they found after 1 month is that the visual analog scale, which is a perception of pain, so the pain scores had decreased by more than 50%. And there was also an improvement in mood and quality of life scales. And so I found this quite interesting. It was particularly relevant, or they had the highest response, I should say, in those with low back pain and neuropathy. But what this really highlighted for me is the need for a context-specific and individualised approach for dietary therapy. And that's what it came out across all of the research, is that there's no one diet that fits everyone.
Right, but those 5 top foods, I think, we do see them a lot show up as sensitivities. You know, the eggs for sure. I get a lot of people that have egg sensitivities. And, you know, I used to do a lot more IgG for food allergy testing. But for some reason, I haven't found really very reliable labs. I had one and that then sold. And so sadly, I don't do it as often as maybe I should, but it's a good thing to remember for people that it is very individualized. I often think that people, you know, that have multiple foods show up on those panels, that it's more of a situation potentially of leaky gut that or intestinal permeability that has so many more implications than just food sensitivities, where foods were basically exposed to the immune system in not a processed way, and so the body basically made antibodies to that food, and that's abnormal. So if you have a lot of food sensitivities, it's very possible that the underlying driver of that might be more intestinal permeability. So I just wanted to throw that in there.
I totally agree. And I don't think that this is certainly something that I'll be jumping at and doing a lot in clinical settings. I think it has utility in some cases. And I would often, after this research, I had a patient come in and she had migraines, chronic lower back pain, and a few other things that suggested food sensitivities. And in that patient, it was like more strongly indicated. So he went down that process. But I think probably, as I said before, it just comes back to it being an individualized approach is what really counts. And certainly I agree with you about the intestinal permeability, that you start to see that. And that's even what the researchers said in this paper, is that it's highly likely that intestinal permeability was one of the drivers of that driving inflammation systemically and then leading to chronic pain.
Great information. Let's move into more of microbial influences on pain perception or drivers of pain. And I think the biggest or the most researched model there might be the model of autoimmunity, right? We have a couple of diseases that are much associated with bacteria that originate in the digestive tract. Can you talk about that a bit more?
Yeah, absolutely. And I think probably the area that I work in most is with rheumatoid arthritis, and that's got quite some strong associations between rheumatoid arthritis and the gut microbiota. Well, not just the gut microbiota, the oral microbiota as well. And the idea with rheumatoid arthritis is it begins at mucosal sites where there's damage to the barriers. So be that the intestinal barrier or the oral mucosa. So, for example, it might be food driving intestinal permeability. It might have been some kind of pathogen. It could be smoking, or it could be the microbial composition itself that leads to gut inflammation and expansion of inflammatory and immune responses. So kind of spill over, I call it, inflammation and immune responses from there. And it's quite interesting in that space, they've actually linked the development of rheumatoid arthritis, or what they suspect the development of rheumatoid arthritis, and some of the inflammatory and pain responses to some specific bacteria. One of those is the gingival bacteria in the mouth. And what they've seen is evidence of bacterial translocation to joint sites of those bacteria. So not just lipopolysaccharides, but bacterial translocation. And then also from the gut, Prevotella copri was the other one. And look, there may be others, but those are the two that they're focusing on at the moment in the research. And they suspect even that some of the drugs that used to treat rheumatoid arthritis work, at least in part, via manipulation of the gut microbiota. So it might be that they're dampening down those responses in some way, or the drivers, or the impact of those bacteria more broadly.
I think it's a whole new frontier that's coming. That's one of the reasons I wanted to have this conversation, because I think that there is a lot more coming down the pike when we talk about microbial influences on all sorts of conditions, right? So besides the rheumatoid arthritis that you mentioned, we also know about ankylosing spondylitis. We know also about endometriosis be associated with different IBS kind of bacteria. So it's just the beginning, I feel. And I think as naturopathic practitioners, we're really well positioned to understand this connection and be ready with some good advice for people. Can we, further to this, I would also say the microbiome in general that can also produce certain metabolites that can dampen an inflammatory response or improve neuronal damage has already been shown with things like indopropionic acid, which is a microbially produced antioxidant that is really, really imperative to prevent things like leaky gut. So this is the exciting, I think, frontier, is to continue to improve microbial health and microbiome health to not just impact pain, but also improve overall health.
Yes, absolutely. I think that this is a space that, well, even looking at the research with osteoarthritis, there's emerging evidence that bacterial composition impacts osteoarthritis, and they're talking now also about, so that's the gut-brain joint axis. Now they're also talking about a gut-brain disc axis, so for low back pain. So in considering the vertebra of the spine. So I think this is certainly space to watch, and an exciting space to watch in terms of potential benefit if we work within that kind of therapeutic area.
And that moves us into this next segment of really what are some of the options for people that are dealing with chronic pain, and what just some basic suggestions. We've already mentioned some of the foods to consider to avoid, which is the saturated fats and sugar and processed carbohydrates or processed foods in general. Are there, and we'll move into what you can offer and what you're offering to your patients, but are there some general suggestions that you have for people?
I'll talk just about diet a little bit more for a start. And this is general advice, not necessarily specific to conditions. But one of the things across the research, and there was multiple different diets studied in multiple types of chronic musculoskeletal pain. And I've also looked at migraines and endometriosis, and there's no consensus across any of those spaces. But one of the common themes was that whole food diets, are the ones that tend to show benefit. And they do that largely by lowering inflammation and oxidative stress, and in some part even through weight reduction, because weight itself can be a low-grade, obesity can be a low-grade chronic inflammatory state. So lowering inflammation and lowering oxidative stress. And they share common attributes such as improved diet quality, increased nutrient density, so they support the gut microbiome, and all a part of the complexity that extends beyond a single diet. So there's lots of opportunities to find a diet that suits a person in particular based on their preferences, but also supports lower inflammation, lower oxidative stress, and whole foods. And if we just expand on that idea of complexity, I think that is the space that we have to look at for chronic pain, looking at the whole person, not just the issues in the tissues, and focusing on what's happening in their body, rather considering what's happening on a biopsychosocial level, or the whole mind, body, spirit, if you like, because there's so many factors within our beliefs, our emotions, and how we view the world and perceive the world that can be considered threatening and drive persistent pain or amplify persistent pain.
So would you say, sorry,
no, you go.
Would you say, like, I'm just trying to understand. So are you saying that, for example, people that generally have more anxiety or are more fear-based would have more pain? Or what are you saying about the biopsychosocial factors?
What I'm saying is pain that is context-driven. And I talked about threat perception before. So threat can come from, say, a signal from the body, but it also can be perceived as perceiving the world as a threatening place, or feeling anxious about the world, or what's happening to you. So yes, those anxiety, particularly anxiety about what's happening in your body, or anxiety about a situation, a place, or a person, it can be, anything really, can actually be in context considered a threat and amplify pain responses. So yes, it is part of a pain response potentially. So some of the features that are in stronger characteristics, if you like, or more strongly associated with pain perception are anxiety, a previous history of depression, and a tendency to catastrophize. So what they've shown in the research is if there's anxiety, depression, or the tendency to catastrophize, sorry about that, and then they've shown that pre-surgery, those people who have those qualities or tendencies tend to be more likely to develop chronic pain post-surgery. So if you like, they're risk factors for chronic pain development. So yes, what's happening from a psychological perspective can drive pain and pain perception, and certainly it can amplify pain, both acute and chronic pain. And if we think about social environment, again, if we think about that from a survival perspective or a threat perspective, we are social animals. We like to engage. So isolation might be one of those things that's considered threatening. Or if there's a little bit of a social anxiety, engaging when perhaps we wouldn't want to might be considered threatening, or a hostile workplace, or the threat of losing your job because you're in pain and you can't do what you used to. So all of those factors can amplify and make pain more chronic and persistent. And that's what I mean by looking at the whole person. It's not just about considering what's happening in their body or the
at
disease
the location
state
of pain, right?
Yeah.
So, okay, so further to that then, how do you address this? And I want to wrap up with this thought about what you offer to your patients, or how you address some of these contributing factors to their pain syndromes.
Yes, of course. In some cases, it's out of my skill set. And so I identify. Sometimes I just think it's about doing a full map of all of the factors that might be contributing to the pain, and identifying what I can work with, and then identifying other areas that the patient might need support outside of my scope for. So it might be referring them on to a pain psychologist or a counsellor, or someone who works with trauma, or a body worker.
Mm-hmm.
It's part of it is actually
the traffic. We're like direct traffic in a way. I have also a big referral base of people, and I think that makes us good practitioner, people that understand their limits and refer on to the appropriate expert in that field. So that's really great advice. But you also have programs and things that people can, just tell us more about your practice and where people can find you.
Yes, so I consult one-on-one with some patients, and I use a really a functional matrix, if you like, to map what's happening for that person and really identify all the inputs to their pain, all the sources of potential threat. And then that allows us to put in place individual strategies to unlearn their pain, if you like, and move through it. So that might be some of what I do, and then some referral or some use of selected things, apps like Curable or the Gupta program that are, pain strategies for, I guess, unmapping or unlearning some of the pathways that have got them into the pain space. So I'll just say there that getting into a chronic pain space may have been an unconscious process, but you can consciously work your way out. And that's where we use some of those strategies like Curable app or mindfulness and meditation or the Gupta program.
Great. Great advice.
Yeah.
And what about and obviously you also dive into their diet, and you do give potentially targeted substances or supplements that are also pain relieving, I'm assuming, right?
Absolutely. And that really just depends what type of pain they have, whether they're coming for endometriosis and related pain, or whether they're coming for fibromyalgia or migraines. It really depends. We work sometimes in the chronic pain space with the brain and central nervous system, but of course we work with any other drivers that are contributing to that pain. So it really depends on what they're presenting with. And on that note, I do group pain management consults for people in pain too. So group pain education and strategies, again, to unlearn pain, as well as individual guidance. And I do that for endometriosis and joint pain. So I've got 2 groups running in that space.
And where can people find you?
At my website, which is my name, anandamahony.com.au.
Okay,
yes.
Fantastic. I love that, unlearning pain. I think that's such a great visual somehow, that you're not just a victim. You can be a participant in solving that for yourself, or at least reducing pain. If you are in chronic pain, a lot of people are in terrible pain and are really sort of held hostage by just basically pain pills. So any other approaches are just fantastic to be able to offer to patients. Do you have any other last minute sort of pearls or nuggets you want to throw in?
Yes. Next year, I'm starting a foundational pain management course for practitioners. So practitioners, naturopaths, and nutritionists who want to learn more about how to manage pain. I'll be doing that from February. In terms of nuggets or other gems, I would just say that there's great complexity in pain, and that can be seen as something that's difficult, but there's also it can also be gems in complexity, because it means it's not a linear pathway. There's not just one way to go. The example I use is osteoarthritis. It's like, I've got osteoarthritis, now it's pain medication, or eventually something like surgery and knee replacement. It's a very linear pathway, but with complexity, there's many pathways in. And that gives us real opportunity to work with people, because we are complex, pain is complex. The solutions don't necessarily have to be complex, but they can work with that complexity. And I love that notion that it's not just a straight one-way road, that we've got multiple ways in to work with a person.
That's wonderful, and a great place to stop. All of your contact details will be available in the show notes. So thank you so much for your time and for your wonderful explanation of pain.
Thanks, Narala. It's been great talking to you.
To access the biphasic diet and the SIBO Success Plan, Or if you're a practitioner and would like to become an affiliate, go to thesebodoctor.com. Thank you for listening to the SIBO Doctor podcast. We hope you find the information in this episode useful in the treatment of your SIBO patients. Thanks to our sponsors, SIBOtest.com, a breath testing service with easy online ordering. Thanks again for listening.